Hello, my name is student Dr. Krysta Sutyak, and I'm going to present our patient Jack to you today. Jack came into my office complaining of recurrent diarrhea and muscle aches. He's a 19-year-old male who recently returned from a family cruise in the Eastern Caribbean. They went on the cruise to celebrate his sister getting into college and himself finishing his GED and being 1 year sober. He has a temperature of 101.3 and also complains of an annoying cough that began about a week ago, although he claims it's mild. Our receptionist saw him take off his jacket gingerly when he arrived this morning, and this revealed red, raised tattoos on his left forearm. Jack has a past medical history of controlled asthma, and we know he's taking Flovent. He is a patient of our primary care clinic, although he usually sees my partner, who is away and unavailable today. There is some more information I'd like to gather from Jack to better gauge his situation. Was Jack sober from? How long was he addicted to? This is important to know so that we can assess for any underlying etiologies that may be related to what he's currently complaining of. It is also important to keep in mind for his treatment and make sure that he receives support so that the possibility of him falling back into his addiction is addressed. He told us he just got back from his cruise, but what does just mean? Does that mean he got back yesterday, 2 weeks ago, maybe even 2 months ago? This is important to know to be able to gauge incubation periods for any infectious pathologies he may have contracted on his vacation. I'd like to ask a little bit more about his tattoo. Is it new? Is it infected? Is it a rash? Where did he get his tattoo done? Did they follow proper sanitary and health precautions? I'd like to ask him a little bit more questions about his cough and his muscle aches and the quality of what that is. I'd also like to know what he did on his cruise. Did he leave the boat? What country specifically did he visit? What activities did he do? Did he eat anything on the ship that made him sick? This is important because this can help us gauge any exposures that occurred. I'd also like to know if the people around him were ill, if he noticed anybody ill that was on the ship. Lastly, I'd like to ask him about how this is affecting his daily life. I'd like to ask him what he does for work and how this is affecting that, as well as his social implications. Based on Jack's symptoms, I've come up with a 5-item differential diagnosis list. At the bottom of my list is acute HIV infection. I've included it on the list because acute infection presents with flu-like symptoms, including fever, myalgia, and pharyngitis. However, I've ruled it out because it doesn't explain the diarrhea, and the proportion of patients who experience a symptomatic infection during the acute phase is debated. Then I have acute hepatitis B. This presents with fever, fatigue, nausea, and vomiting, as well as right quadrant pain and jaundice. Jack doesn't complain of right quadrant pain, fever, or jaundice. And in the United States, vaccination against hepatitis B is recommended for children ages 0 to 18, so chances are he may have received the vaccination. My second and third diagnoses are neurovirus infection and traveler's diarrhea. Both of these infections have a main complaint of diarrhea, and they have acute onset within 24 to 72 hours of infection. However, they usually just treated with oral and IV hydration and tend to go away on their own, so I do not believe that they're urgent. Abdominal tuberculosis is my main diagnosis. This fits his symptoms as it presents with abdominal pain, muscle aches, and fever. He's also complaining of a cough, which may be unrelated or related to his asthma. However, it also could be related to abdominal tuberculosis. Additionally, he was recently on a cruise ship with a lot of other people and went to a new geographic location in his travel, so this presents routes of exposure. Abdominal tuberculosis can be contracted a couple of ways. The first is ingestion of infected milk or sputum. The second is spread from a primary site via the bloodstream, or if it's in the lymph nodes, via lymphatics. The third is from direct spread from a local site. In the case of abdominal tuberculosis, this would be a site located in the peritoneum. Based on Jack's history, I would think that the most suspected route would be ingestion of infected milk or sputum. But we should ask him if he's ever had symptoms or if he's been sick recently to rule out the other routes of infection. Signs and symptoms of tuberculosis are generally pretty wide, but they do include fever, weight loss, diarrhea, and abdominal pain, hepatomegaly, and splenomegaly. I do believe that there are some pertinent risk factors for Jack in contracting abdominal tuberculosis. Alcoholic liver disease has been shown to be a risk factor. While Jack is quite young, 19 years old, he said he was previously addicted to something. While we don't know what this is, if this was alcohol, we could potentially see changes in his liver. However, this would depend on how much he drank and for how long he drank, as well as other aspects of his drinking habits. Secondly is HIV infection. HIV infection is a big concern with tuberculosis. Tuberculosis is the number one cause of death in HIV-infected patients according to the CDC. This is relevant because Jack could have had previous routes of exposure. Like we said, he is sober from something. We'd have to ask him more questions about this, but if he has been an IV drug user, this is a prominent concern, as it potentially is a route of exposure. Also, this tattoo could also provide a route of exposure. The third is immunosuppressant state. The two above contribute to this, but he's also taking Flovent. Flovent is an inhaled corticosteroid, and generally, inhaled corticosteroids do not have a systemic effect. However, it is still listed as a risk factor, so should be considered. The fourth is travel. He has recently traveled to an area where tuberculosis has been found. And the fifth is that this infection usually affects people of reproductive age, which is what Jack's current age is. There are a couple of recommended diagnostic tests for patients where you have suspicion of abdominal tuberculosis. So these are things that I would like to recommend for Jack. The first thing we do is an abdominal imaging. This can include barium studies, CT, MRI, or ultrasound. In the far left frame, we have a picture of a CT scan from a patient with abdominal tuberculosis. Frame A shows loops of small bowel concentrated in the center of the abdomen, and phase B shows the accumulation of ascitic fluid. We want to do these studies to look for visual changes that were seen in tuberculosis, but also to rule out strictures, fistulas, or blockages that may have occurred. Next, we need to do a chest x-ray. This is to assess for the spread of pulmonary tuberculosis. This is particularly important in Jack since he does have an annoying cough. It is shown that 15 to 25% of the cases of abdominal tuberculosis also have pulmonary TB, so we need to do our due diligence and make sure this isn't the case for Jack. Unfortunately, biopsy is required for definitive diagnosis and is considered the gold standard. This can be minimally invasive by an endoscopic GI mucosal biopsy or via a surgical biopsy. When looking at the tissue obtained, we're going to look for granulomas or acid-fast bacilli. In the histological picture included, we can see the epithelioid granulomas and the Langerhans-type giant cells. We also would like to take a culture from the ascitic fluid, and we're looking for a white count between 1500 and 500 and has lymphocyte predominance. There will be slight to low glucose and a total protein greater than 25 grams. In the bottom flowchart, we do see that there isn't a suggested approach for diagnosis of abdominal tuberculosis based on the invasive nature of the diagnostic testing. So if you have high rates of suspicion and an ultrasound of the abdomen comes back positive, it's likely you could just consider treating rather than going to the more invasive measures of diagnostic testing. Abdominal tuberculosis can infect the esophagus, stomach, jejunum, ileocecal junction, or the colorectal area. Ileocecal junction and the jejunum account for 64% of cases, with the ileocecal junction being the overall most common. This is due to factors including area of stasis, area of most reabsorption, and there's a bunch of lymphoid tissue. The way that this infection occurs is the Mycobacterium tuberculosis bacilli are ingested and they travel through the GI tract. They attach to the mucosa and develop into epithelioid tubercles in the submucosa. In 2 to 4 weeks, these tubercles undergo caseous necrosis, which leads the mucosa to ulcerate. This ulcerated mucosa then allows for the spread to the surrounding tissues as well as the lymph nodes. If we look at the attached picture, in frame C, we see the ileocecal valve with ulceration over the mucosa. In frame D, we can see superficial ulceration of the mucosa traveling into the ileum. Most cases of abdominal tuberculosis can be treated with medication. In later stages, surgical resection may be necessary. Surgical intervention is also needed if there is blockage, abscess, or fistula. In Jack's case, I'd like to start him on the standard anti-tuberculosis multi-drug protocol. This includes 2 months of isoniazid, rifampin, pyrazinamide, and ethambutol, and then 4 months of isoniazid and rifampin. It's important to look at the strain of TB he has before starting him on these medications to ensure that they're susceptible to this protocol. It's also important for us to get a liver function test because specifically isoniazid can increase the risk for hepatitis, especially in people who have a history of alcohol use. We will also need to monitor his liver functions throughout his treatment and repeat these tests every month. I'd like to address other medical issues with Jack. I'd like to investigate the tattoo and make sure there isn't a potential infection that needs to also be treated. I would also recommend testing for HIV in Jack given his history. Tuberculosis is mandatory to be reported by the CDC, so I would make sure that the local health department is notified of his case. When discussing the treatment plan with Jack, I would want to make sure he understands all the risks and benefits of the treatment that I'm suggesting, but also the risks and benefits of not doing the treatment. I would make sure to answer any questions he has. I realize that this is a 6-month-long treatment, so I would make sure that Jack knows that we're here for him for whatever he needs throughout the process. I'd also advise him to contact us immediately if he has any worsening symptoms. Specifically, worsening abdominal pain and constipation are concerning due to the increased risk of bowel blockage, which would lead to an emergent situation. I'd also ask him to watch for reaction to medications and for jaundice to make sure we're not missing anything in his liver function. I'd also advise him to call us if his fever worsens. When considering the ethical implications for Jack and those who are involved, I would like to know how he contracted this disease. Are other people infected who were on the cruise ship as well? Is Jack's family infected? What is the emotional effect this will have for both Jack and his family? Who has he interacted with since he returned home? Are they possibly infected? What does Jack's support system look like? As I mentioned before, this is quite a long course of treatment and a serious illness. Does he have friends or family he can talk to and seek support from during his recovery? I'd also like to know if he has any objections to our course of treatment and discuss these further with him. I would like to thank Dr. Farrell, Dr. Town, Dr. Stasio, Mr. Schwartz, Tina Hefty, and Jennifer Fisher for their assistance and support throughout this process. Thank you very much.